Hi, good afternoon. This is Angela Tolosa here at Council of State Governments Justice Center. Welcome you all to our Risk-Need-Responsivity 101, a primer for SCA and JMHCP grant recipients. We are very excited to have you all on our webinar today, and we're very pleased to have David Amora, who is Director here at National Initiatives, be able to present on this topic, of which he is one of the leading experts in the country. I will be doing some initial housekeeping for folks. Just to let you know, if you have any questions you'd like to add during the webinar, you can feel free to add them in at the lower right-hand Q&A box, and we'd be happy to assist you with any logistical, technical questions, or even if you'd like to submit any questions on the content. We will be running the webinar with a presentation from Mr. Amora, and then at the end of the presentation, we will be having Q&A. So please feel free to submit your questions. Great. So Council of State Governments Justice Center is a national nonprofit, nonpartisan membership association of state government officials. We are here to engage all members of 3 branches of state government, and we provide practical advice informed by best available evidence and data in all the work that we do. We, as part of CSG Justice Center, we are the technical and training and technical assistance provider for all the Second Chance at Grantees. To do this work, we run the National Reentry Resource Center, which is a project of CSG and supported by Bureau of Justice Assistance, the same entity that funds all of the SCA and JMHCP grants across the country. We have worked with over 600 grantees since the Second Chance Act has been authorized, including 40 state correction agencies, and provide targeted technical assistance that many of you already are very much aware of. As you know, our website is here at CSG Justice Center NRC, and I definitely encourage all of you to be signing up to our newsletter that comes out every 3rd week of the month in order to get information about funding opportunities and to learn about the latest research to help you in your reentry programming. In addition to working with the Second Chance at Grantees, we work with a comparable number of justice and mental health collaboration program grantees. So since 2002, since the release of the Consensus Project report, we have been providing TA to state and localities working to improve public health and public safety outcomes. So since the inception of the grant program in 2006, we've been working with over 320 grantees, and our programs are diverse and include several different types of entities, including law enforcement initiatives, alternatives to incarceration projects, specialized courts, and community-based reentry programs, among others. We definitely also would love for you all to sign up for our monthly newsletter that comes out the first week of every month, so that you can get information on funding and research. And the last thing I'd love to share to all folks on the audience right now is information about our What Works in Reentry Clearinghouse, which is housed at the CSG Justice Center website. The web address is there, whatworks@csgjusticecenter.org. It is a one-stop shop for research on the effectiveness of a wide variety of reentry programs and practices that's been developed by the NARC as well as the Urban Institute and provided by BJA. It's a great resource that you can use to help you find evidence-based programming or what evidence is saying about programs and practices that you may be implementing as part of your grant program. So please do check out What Works in Reentry Clearinghouse. Great. Okay, so we're going to now segue. I'd like to introduce Mr. Amora. He is part of our National Initiatives Division and has been working with several legislators, consultants, and analysts all over the country to raise public awareness about criminal justice issues, has authored the Justice Center publication, Adults with Behavioral Health Needs Under Correctional Supervision, a Shared Framework, and his previous experience in criminal justice and human services includes extensive work with adults, juveniles, individuals with developmental disabilities, substance abuse, mental illness, and or sexually violent behavior. So now I will turn it over to Mr. Amora.
Good afternoon, everybody. Welcome. Very pleased to have you join us, and I'd like to say something that I'm sure has been said to you all before, which is that you are among a select few, that there are far more folks who apply for these types of grants than ever receive them, and the fact that you have received them speaks very well of the work that you have been doing. Today's webinar is a 101, and I have no doubt that for some of the folks on this call that you already know the basics of risk, need, and responsivity and risk assessment, but it's really important that everyone that we're working with really has a baseline and that it's the same baseline, because part of what goes on in the technical assistance that we do is really looking at how well folks implement risk, need, and responsivity, how well they implement risk assessment, and how well the results of the risk assessment lead to evidence-based programming that we know will make a difference in working with folks who are in the criminal justice system. The webinar today will actually have three components to it, but it will be broken down into two categories. And the first larger category will be talking about risk, need, responsivity and all of the components. The second will be focusing particularly on behavioral health issues. It is important for folks who are working in the behavioral health field to understand risk, need, and responsivity. And for those of you who are working in the more traditional criminal justice world and perhaps don't have identified behavioral health clients, I'd like to suggest to you that it's important that you understand the behavioral health issues that we will be talking about as well, because in point of fact, the number of folks that are in the criminal justice system who have behavioral health needs, even if they're not directly identified, are very significant, and very often what happens is we miss them. And so it's better, much better, to actually have all of the necessary information. Today's presentation will, in addition to these two larger categories, be broken down into these three segments that you see here. First of all, a discussion about reforming system-wide policies to make sure that resources are spent in the best way possible, in a way that will make a difference, if you will. The second component will be talking about implementing evidence-based interventions effectively. And then the third will be talking about specifically integrating treatment and services, the issue of folks with behavioral health needs, and also criminogenic risk factors. So that's the outline of the afternoon, or at least of the next 45 minutes to an hour. And as I said, this is a 101, and so we are going to make sure that when we're done, everyone has the same baseline, and we realize that some of you will have additional information, and at some point in the not-too-distant future, we'll be doing a 201 version of this for folks who already have the 101 knowledge under their belt. So let's talk about the issue of reforming system-wide policies to make sure that resources are spent well. Now, the reality of it is that all offenders don't pose the same risks. We tend to know this even without risk assessment, but in fact, we consistently see in many jurisdictions that all folks get almost the same treatment responses and get very similar kinds of supervision responses. Even when put on different caseload levels, often they're responded to in a similar manner. But in point of fact, all folks don't pose the same risks, and utilizing resources for low-risk folks is a terrible waste of dollars and person power, but it also ultimately can increase the risk of low-risk individuals, and that's very problematic. We really have to make some choices about how we spend supervision and case management time, how we spend treatment time, the amount of treatment that we give to individuals, and what those best types of treatment are. And in order to do that, we have to think about it from a systematic or system perspective. So when we're talking about reforming policies, we're talking about doing a number of things in terms of making sure that resources are spent in a way that will make a difference. The first one is to use a risk-need assessment or a risk-need instrument. And what you'll see here, of course, is the word validated in front of that. And what that means, we'll talk about in just a minute or two, but there are sort of two ways to think about it. One is there are what are called off-the-shelf tools that were validated, meaning they were shown to work. You can purchase them and you can use them just as is in the work that you're doing. But the ideal, really the appropriate way is to validate folks on your local population, and we'll come back to that. The second component has to do with then once you get the various determinations of risk of different individuals, that's how you make determinations about what you do with your resource allocation and with which specific programs you provide to individuals. And it's really important to develop policies that are statewide that really support the implementation of the risk-need principle. The risk-need principle, which again we'll talk about more in just a few moments, really is the single most researched and evidence-based principle that exists in the criminal justice world if we are looking at the issue of lowering recidivism. So what is the risk-need-responsivity principle or model? Well, that comes to the issue of what works in reducing recidivism. And what you see in front of you are very, very brief descriptions of the concepts that we're talking about. The risk principle basically says that you match the intensity of what you're doing to the likelihood of the individual committing some type of new offense, whether that is reoffending with a new criminal behavior or perhaps failing under community supervision through some type of technical violation that may not be a new crime, but still is something that will count as a new offense and get them back into the system. The second issue, the second principle, is the need principle, which is basically targeting the kinds of things that have a relationship to people acting in a criminal manner. You can think of risk and need as two sides of the same coin. In fact, some would argue it is all the same, that it's really all about risk, that need is about what it is that you provide or you respond to. Without getting into all of those different arguments that we could spend a whole webinar on, what are the nuances, the bottom line is when we're talking about the risk principle, the first issue is there are a number of known risk factors, and the more of those risk factors that folks have, the greater the intensity of the response that we need to give in order to lower the possibility of future criminal behavior. The second issue is, in terms of need, is that what you need to target are the kinds of things that drive criminal behavior. And then the third issue is responsivity, which has to do with how you tailor the interventions. And here's a very simple way to think about responsivity. Some of you on the phone are listening to my voice. Well, you're all listening to my voice, hopefully, but some of you are getting the idea of what I'm talking about by listening to my words. Others of you are very happy that the pictures are up there on your screen and that you're able to read the words and you're able to look at the concepts that are there because that works better for you. Others of you probably learn best by doing, which makes this the less than ideal learning situation for you, but hopefully you're motivated enough to be able to struggle through the two choices of either listening to my voice and or looking at the screen in front of you. That's what's called individual responsivity or personal responsivity or specific responsivity. Excuse me. The other type of responsivity is called general responsivity, which basically focuses on the issue of what makes a difference, what are the things that are impactful, and what we know is that the things that are most impactful are cognitive behavioral responses or interventions. And again, we'll come back to that soon. So when we talk about risk factors or dynamic risk factors, when we talk about the things that need to change, this list of 8 items are the key criminogenic needs or dynamic risk factors that exist in terms of drivers of crime. And what you see are the top 4 bolded, and that's because these central 8 have what's called within them the big 4, and the big 4 are the top ones. What does that mean? Well, what it means pretty simply is that if any of those big 4 exist, you must deal with them. 1, they are stronger drivers, and 2, if you don't deal with them, you can deal with the bottom 4, but you still will not get the changes that you want in terms of lowering recidivism. And so what you see here, again, are things like antisocial behavior, antisocial personality pattern, antisocial thinking, antisocial friends, and antisocial attitudes in terms of how you see the world. What's important is to understand that the word antisocial, the way that it's used here, is not meant as a mental health diagnosis or as a personality disorder. In other words, we're not talking about antisocial personality disorder. It's true that some folks may have that, but many folks with these four antisocial kinds of attitudes or issues may not actually qualify for a particular diagnosis. So it's important to not confuse the two. Or to put it another way, far more people have antisocial behavior patterns, thinking, and friends than have an actual diagnosis of antisocial personality disorder. Looking at the bottom four, you see additional important components: family or marital problems, poor school and employment issues, very few leisure, pro-social leisure and recreation activities, and substance use or substance abuse more specifically. Now, I want to make a point about substance abuse. One, it is both a risk factor and a responsivity issue. That is to say, it not only can be a driver, although by itself it's considered to be a relatively weak driver, it is also a responsivity issue. That is to say, it gets in the way of the kinds of changes that somebody needs to make in order to lower the likelihood of recidivism. And so the fact that it's number 8 doesn't mean that it's the least important or that it's the weakest. And I want to make sure that you understand that, in part because we have recent research that suggests that people can have other low-risk factors with a high substance abuse need and still end up failing at a significant rate. And so what we're seeing right now is some new evidence that's suggesting that the role of substance abuse may be more powerful in individuals failing than what we historically thought. Now, that research is relatively new. There's still a lot of back and forth argument about it, but I think that it's very important to hear about it and to understand it, because I suspect that as we get some additional data over the next few years, we're going to see the issue of substance abuse, and particularly substance dependence, to be a much bigger driver and something we need to respond to much more powerfully than we have done traditionally. When we look at this issue of assessing risk of reoffending, the issue has to do with how do we separate folks out? How do we think about them in different ways? And you see in front of you a chart here that basically looks at 3 levels of risk: low, moderate, and high. And you see some numbers under there, and these are for examples only. These numbers are not specific to be connected to what's happening in your jurisdiction. And you see here that, well, folks that are sort of low risk might have a fairly low likelihood of being rearrested, moderate, significantly higher, and high, very significantly higher. But the way that it looks right here is that you know that that's true, but you don't really know how to separate out these folks. Well, when you begin to assess risk of reoffending, you're able to now begin to determine who is who. You're able to look at the fact that some folks fit in one category, some folks fit in another category. And if you go to this third slide, what you then do is you put them in the different boxes or the different categories, the different groupings, so that you can make some decisions about how high the supervision level should be and what the program intensity should be, how much you should be responding to them. It's a very different way of thinking about it than having everybody scattered, as you saw in the first box, or even understanding that people were different, as you saw in the second box, but then not breaking out your responses based on their level of risk. While it is true that in most jurisdictions today, people have an ability to determine differential risk, although the accuracy of that varies dramatically from jurisdiction to jurisdiction, it is still true that in many jurisdictions, once that determination is made, how people are referred to programming and what they get for programming is pretty much the same thing. And so the actual case planning and intervention does not flow smoothly from the determination of risk that occurs. This is important because when we look at cognitive behavioral interventions, they're the most effective with people who are in the moderate and higher risk categories. They don't make any positive difference for low-risk folks, and as I said earlier, they arguably can increase the risk of the lowest risk in that bottom group. Now, there are some challenges when we're talking about utilizing risk instruments. They're not perfect, and some of you may have seen this recent article in the paper talking about risk tools, and it was frankly not a very well-written article in that it talked about surveys, it described the risk tools sort of inaccurately, and it suggested that risk tools should be able to determine the risk of individuals as opposed to groups, and that somehow this was failing. And it was talking about an example of a very bad thing that happened, and that can happen. That's not the issue. But the fact of the matter is that the article was essentially suggesting that risk assessment is nothing more than flipping a coin. In point of fact, good risk assessment is far superior to flipping a coin, which is pretty much where we were for the 50 to 60 years prior to utilizing risk assessment. So what about some of the challenges of utilizing risk assessment? Well, the first issue is that to use a risk assessment, it has to have a sound theoretical basis, and it has to have an empirical basis. You can't just put together 10 or 12 items and decide, hey, I'll ask these questions and this will give me the answer. They're the most effectively predictive when they're validated and normed on your local population, typically on a state population, although in some cases that might be a county population, depending on what the tool is being utilized for. The validation helps inform cutoffs, meaning where low, moderate, and high-risk individuals would fit. And it needs to be revalidated every several years. Finally, or second to last, I suppose, they're useful if what happens is that the responses that you give, meaning the programming and supervision responses, are done in accordance to the risk-need principle that we were just talking about. And overrides should not be used routinely. They should be used really fairly rarely, and they should require a second person's approval, a supervisor's approval of some sort. Otherwise, you lose the usefulness of the risk assessment, and what happens is that subjective opinion ends up ruling the day. Now, some additional issues that have been coming up. Forgive me for those of you if you cannot tell. I'm having my spring allergies, so I'm taking slugs of water between my different discussion here. One of the things that's coming up now is that when we talk about the issue of different levels of risk, we're beginning to explore more than 3 levels. We now have enough science to know that we can discriminate better than we currently are with 3 levels of risk, and we're looking to expand this to 5 levels. We're looking to be able to improve what we're looking at in terms of low risk, to be able to determine those people in the low risk bin who are actually at no greater risk of committing a new crime than those in the general population. We're still a couple of years from there, but I just want you to know that there's a lot of exciting work going on among test makers and researchers in the field, really looking to further improve the discrimination and the accuracy of risk assessment. Now, when we talk about risk assessment, there are 2 components, and there are what are called static factors and what are called dynamic factors. Individuals are assessed for, of course, recidivism risk and then specific criminogenic needs that contribute to recidivism. Static factors are unchangeable, just like it sounds, right? Criminal history is a static factor. Number of priors, for example, would be a static factor. Age is generally a static factor, meaning that it's not going to change from day to day or from week to week or from month to month. There are some differences in terms of age that relate to under a certain age versus over a certain age, but we'll talk about that at a different point. Dynamic factors are changeable issues. What are dynamic factors? Well, there's a variety of them, and all of the criminogenic needs that we've mentioned, those aids, are dynamic. So those central 8 are all changeable. There's nothing about those 8 items that we discussed, from antisocial patterns to behavior, to substance abuse, to employment issues, to intimacy or family issues. There's nothing to education. There's nothing about those that are not changeable. They are all dynamic risk factors, and they can be impacted by good program intervention. When we're talking about utilizing risk assessment and risk levels, we're talking about how you drive the allocation of resources. It means that staffing reflects the population size and the risk levels. It means that the written policies guide the allocations of how it is those resources are used. It means that caseloads are based on this. And you don't have, for example, a high-risk caseload that has the same number of folks on it that a low-risk caseload would have. And to be clear, when I'm talking about caseload, this could be a caseload in terms of a supervision caseload, or it can be a caseload in terms of a program or treatment caseload. You should not have the same numbers. Now, different jurisdictions do this in different ways. Some of them have specialized caseloads with lower numbers. Others mix the different folks on caseloads and then determine the caseload size depending on the particular breakdown of lower or moderate or high risk, and most typically moderate and high risk individuals. There isn't one way to do it. But if what you have is a situation where basically everybody has the same size caseload, that tells you that determinations are not being made by risk. Next is the issue of the types of programming and the availability of programming. I was recently in a jurisdiction that had a large number of programs, I mean literally over 100 programs, which on the one hand was really very nice. On the other hand, the majority of the programs had no known relationship to lowering recidivism. And the determination of referral to the programs was not made based on the risk level or the criminogenic factors. So I was in an area that was fairly highly resourced and was spending a significant amount of money, but was in fact really not doing that much to lower the likelihood of future recidivism of the folks that they were treating. So it's important that, first of all, folks partner with agencies that adhere to the risk-need principle and that offer evidence-based programming, again, which we'll come back to, for higher risk individuals. And it's also important to be sure that the programs that are reentry programs, or that are programs for folks who are in the criminal justice system, whether that's while they're incarcerated or once they come back into the community, are programs that have been shown to have a positive impact on lowering recidivism. This once again means that you need written policies that really help focus supervision, treatment, and program dollars, that it helps to have developed clear policies and procedures to describe who's going to perform the risk assessments, what the time frame is to perform a risk assessment, when reassessment of individuals should be done. Also in policy should be, how does risk assessment inform case planning? How does it inform the program selection? And how does it inform contact standards? Not everyone needs to be seen with the same frequency. Not everyone needs the same intensity of programming. Not everybody needs every particular stipulation that might be available to give in probation, or every specific, or every specific programmatic response that an agency may have to offer. When everybody's getting the same thing, it tells you that the risk assessment results are not determining the case planning. The next component has to do with oversight and accountability, which includes personnel evaluations. Often I'm in jurisdictions where the personnel evaluations have no relationship to what we're talking about here. So on the one hand, the good news is the jurisdiction has said we want to do this. On the other hand, when you look at how they evaluate staff, they evaluate them on criteria that have no relationship to putting into place a risk-need model. So good personnel evaluations and good program evaluations are directly related to ensuring that the policies and procedures that around risk, need, and responsivity are implemented with fidelity and with consistency. So we're now going to move to the second component, which is how do you implement evidence-based interventions in an effective way? So let's talk about this issue about implementing things effectively. Once again, when I go to many jurisdictions, they have put together an excellent plan, but where it falls down is where the rubber meets the road. Where it falls down is when they actually try to put these things in place. So why does it matter? Well, there's a number of things. The first issue is there needs to be a strong policy framework in place, because if you want to have recidivism reduction, the policies need to clearly be aimed at doing that. The next issue is you have to build the capacity, right, to meet the needs of higher risk individuals. You can have a great policy, but if you don't actually then build the programming in the right way, you won't see those changes. What this means is that all of the correctional staff, from administrators to direct line staff, need to have the power to drive offender change. What does that mean? It means that they need to equip the workforce with the necessary skills, and they need to have the administrative supports in place. That means that administrative policies need to be directed toward recidivism reduction. It means that the training of the workforce in terms of what they're doing around supervision and programming needs to be focused on recidivism reduction. And it means that there needs to be a quality assurance plan in place to make sure that the policies that have been developed, the processes that are put in place, are being followed. So it entails a number of things. It entails appropriate staffing. It entails continued staff development, ongoing quality assurance, and as I've already mentioned, the issue of performance evaluations being based on the priorities and recidivism reduction goals. Now, continued staff and development is really important, and I just want to take a second to mention that again. There's two issues. There's the issue of individual or initial training, which is very important, and we've gotten much better at that in our field. Where we tend to fall down is on the ongoing training. We don't coach enough in an ongoing manner. We need to build into our systems ongoing coaching possibilities. Sometimes that's done by building it in a supervision structure. Sometimes it's done by literally creating a separate group of folks who do the coaching, whether that's internal or that's external in some contracted fashion. Again, there are several ways to do it, but the idea that one would get even 40 hours or 80 hours of training and then over the course of the next several years not have things become less effective is a poor idea, because we know again and again that it will. You need to have good initial training, you need to have ongoing coaching, and you need to have routine, basically annual refresher courses. Finally, you need to allow for the issue of staff turnover and make sure that you have the ability to bring new staff on board and train them as soon as they get there. And again, there are a number of ways to do that, including connecting them up with current staff, including having an internal training component, including how it is that you do supervision. There is no one answer, but the ultimate result is that it cannot be a one-time training process and hope that you will then have fidelity to what you want to do over time. What we're looking for, of course, is a balanced approach. We want to hold offenders accountable. This is not some type of if you will, touchy-feely issue where if we're just nice, people will behave well. Accountability is important. There are conditions that have to be met. There are stipulations that need to be met. There are policies and expectations that we have That doesn't change. But what we are, or what we are supposed to be in the correctional world, whether we are supervising agents, whether we are correctional officers within a facility, whether we are treatment providers providing community-based treatment, whether we are mental health providers providing mental health treatment, what we are change agents. And what our goal has to be is habilitation. Our goal has to be to provide positive change that will make them less likely to engage in criminal activity in the future. And please note the word habilitation. Rehabilitation suggests that we want to bring people back to a prior level of functioning. In most instances, the folks that we're working with's prior level of functioning was pretty poor. In fact, it's what helped lead them to the problems that they're having today. We're really looking to bring folks to a level of functioning greater than they have probably ever had in their lives. We are looking to habilitate, to really create something new, not to bring them back to some former level. When we look at this issue of targeting criminogenic needs to improve outcomes, what we know is that the more of them that we target, the better outcomes that we get. So if we were to target all 8 that we talked about earlier, we would get the best outcomes. And you can see targeting 6 or more here, looking at this chart, you definitely get the best outcomes. But I want to point out that even if you just target 1, you get an okay outcome. If you target 2, you get a really okay outcome. You don't have to target all 8. And by the way, if you're wondering about the right side of this chart, that's what happens when you don't target any of them. You basically make it worse. And that's not our job. That's not what we want to do. But I want to be clear that while the goal is to target as many criminogenic needs as possible, we can't always do that. But that is not an excuse to not target any of them. If you can only target 1 to start with, fine. And then in a year, focus on being able to target 2 or 3. The goal is all 8, or as many of the 8 as an individual has, of course. But don't essentially refuse to target any of them if you can't target all of them. If you just hit 1 or 2, you will still see significant improvements in your clients. So the next issue then is, well, when we're targeting them, when we're doing this sort of thing, what are the things we're using? Should we be sitting down and having conversations with them? Should we perhaps do the old style of having them on a couch and doing some type of analysis? Should we do even traditional mental health that might work with folks that have other problems of living? And the answer to all of that is pretty much no, we shouldn't be. That what the evidence tells us pretty simply, pretty straightforwardly, and pretty powerfully is that the best interventions to utilize when we're looking to resolve or ameliorate criminogenic needs are cognitive behavioral interventions. Now, cognitive behavioral interventions take on different forms. There's cognitive behavioral programming or restructuring that we see, and you see a variety of programs that we'll talk about in just a moment. And then there's also cognitive behavioral therapy. We're not really talking about cognitive behavioral therapy in this discussion. While that is an important component, once we start getting into cognitive behavioral therapy, we're specifically talking about licensed mental health professionals doing that. When we're talking about the more general cognitive behavioral interventions, many types of folks can be trained to provide those interventions, and they don't necessarily have to be mental health clinicians. So what we're talking about when we're talking about cognitive behavioral interventions is cognitive restructuring. We're talking about changing how people think. We're talking about changing their beliefs. We're talking about the development of appropriate pro-social skills. We're talking about developing pro-social problem-solving skills. And we're talking about working with higher risk individuals because that's who it makes a difference with. It's also important that doing these programs by themselves and changing nothing else will not have the impact. In other words, if you do a cognitive behavioral intervention in a prison setting, but you run the prison in a way that is demeaning and dehumanizing, then that intervention will not be effective. If you do it in the community, but your supervision styles do not reflect what it is that you are teaching these individuals. In other words, if you have a punitive, negative supervision style while attempting to change people's thinking about criminal behavior, it will not be effective. So it's not just the issue of give people a 20-week program, a 12-week program, a 50-week program. It is the issue of giving folks these programs and really having all of the people that are involved with them reinforcing that programming, whether that's correctional officers, whether that's clinicians, whether that's community program providers and community supervisors. And to be clear, other clinical needs cannot be ignored. But where you see the mistake happening sometimes is that there will be a diagnosis of a particular problem, for example, an anxiety disorder or depression or a substance use disorder. And those will be responded to, and they should be appropriately, but it will then be assumed that by responding to those, the problem is solved. In point of fact, that will not solve the problem. It will solve that immediate issue, perhaps, but it will not solve the larger problem, and a little bit later I will tell you how not solving that larger problem ends up causing the person to relapse with those other problems down the road. Okay, so when we're talking about evidence-based program models, what are some of those that are out there? Well, the four of the most common ones when we're talking about dealing with criminogenic risk are moral recognition therapy, reasoning and rehabilitation, thinking for a change, and aggression replacement training. All of these have varying degrees of research behind them in terms of their effectiveness. They all have research behind them in terms of being effective. Again, you can find different levels of research depending on what you look at and excuse me, depending on who the groups are or the groupings are that they're using them with. There are also some significant differences in terms of the cost factors between utilizing these different programs. Some of them have costs that are related only to training. Some of them have ongoing costs. And so you have to take those things into account when you make a determination as to what program or series of programs that you want to utilize. And then at the bottom, you see a couple of examples of evidence-based behavioral health interventions for folks that we're talking about in the criminal justice system, one of them being modified therapeutic communities in terms of co-occurring disorders, folks with substance use and mental health disorders, and then things like assertive community treatment or ACT for folks with significant mental health disorders. I mentioned before the issue of responsivity. Now, responsivity, interestingly, is both very important and perhaps sadly the most poorly understood of the three principles. It's the most poorly researched and in some ways the most poorly utilized, if you will, when you look at programming around the country. Nevertheless, it is, I think, at least in my opinion, going to be one of the major challenges of the next decade. In other words, I think that we understand the risk principle, we understand the issue of criminogenic needs, we have seen effective decreases in recidivism by utilizing those programs, but we have not lowered recidivism to the degree that we can say we have won. There's a lot of room left to go. I think that one of the key ways that we are going to see improvements in the next decade in lowering recidivism is by better understanding and utilizing the responsivity principle in this model. which means better researching it and better putting it into play in different jurisdictions and with different types of populations of folks that we're working with. Now, having said that, what are some of the things we already know? Well, we already know that many of the folks we work with are not particularly motivated to change. And in truth, let's be honest, most of us are not all that motivated to change. And if we did a call-in poll, I suspect I could find most of you that would like to do something different in your life, and someday you're going to do it. But it's not today, and it's not next week. Well, you take that, you add it to folks who are in the criminal justice system, who often don't feel that there's any ability to have things change in a positive manner, and you very often have significantly low motivation for change. We now know that there's a number of ways to enhance folks' motivation to change. The most common thing that folks talk about these days is that of motivational interviewing, which has been around now for a number of years. It's been shown to be highly effective in the initial stages of working with somebody in terms of getting them to buy into what it is that we're doing and to increase their interest, if you will, in change, their motivation in change. The second issue is really fine-tuning what we do in a way to make sure that we're providing responses that will work. So, for example, some folks with mental illnesses have particular cognitive impairments that really require some adaptations to how it is that we provide the cognitive behavioral interventions. It's not that we change the interventions, that we change the delivery method. The same is true for some folks who have particularly lower cognitive functioning. They clearly know what they're doing. They clearly know that their behavior was criminal, but in fact, their learning style is significantly impacted by their cognitive functioning difficulties. They can still benefit from cognitive restructuring, but how we deliver it, the frequency of it, the style of it, and the length of it is rather different than what we would do for other folks. So we have the issue of basically looking at not just we have a program, whether that's moral recognition therapy, reasoning and rehabilitation, or thinking for a change, but we have the issue of thinking about how we deliver those to different groups of individuals. And I haven't even touched issues like people's personal learning strengths and weaknesses, their learning style, cultural, ethnic, racial, and gender characteristics. There are many of these. And the truth is, I know of nowhere that is hitting all of these things well. But it's important that we acknowledge that they're there. It's important that we begin to hit as many of them as possible. And it's important when somebody isn't doing well for us to not first go to assuming the reason for the failure is something bad about them, but to think about whether or not there's a reason for failure that's related to these issues that I'm mentioning. And that if we make some tweak, some change, modification in what we're doing, we can actually improve the likelihood that individual will succeed. And then there's that issue of intensity and dosage. Now, the truth is, there are relatively few studies looking at the issue of intensity and dosage of cognitive interventions, but we have some. What we know is that the idea of we'll keep people in cognitive programming until their supervision ends is fundamentally the wrong thing to do. What we know is that there are some good estimates of the appropriate amount of hours needed to create the change necessary to lower an individual's likelihood of recidivism. And what you see in front of you is our best information at this time. That for higher risk individuals, you're talking about 300 hours of intervention, and for moderate risk individuals, you're talking about 200 hours. And you're talking about some way of how you provide that in the sense of you want to provide more of it earlier on and less of it later on. So greater intensity earlier on, and then you can spread it out, if you will, more later on. Now, we could go into a very long discussion about the difference between do you provide some of this inside the walls if somebody's been incarcerated versus outside. We could talk about whether or not this means doing it several times a week, or whether or not we're talking about 1 hour at a time or several hours at a time. There are a lot of interesting factors to be discussed, and there is no one right answer, though there are some decent guidelines, and the articles that you see cited there at the end of this slide indeed do provide some of that information. We have access to those articles and are happy to share them with anybody on the webinar. What I want you to think about, though, is the overall numbers. If you're running a program that sees people forever, I strongly urge you to stop that and to begin to consider the appropriate dosage. If you are running a program that sees people 10 times and it's over, I urge you to stop that, because the likelihood of that being what they need is fairly low. Now, there are some exceptions to that, a skills training program, perhaps a family education program, et cetera. But if your program is designed to lower recidivism, too short or too long is ineffective, and in some instances, particularly the too long ones, can increase recidivism as the individual loses hope of ever getting out of the cycle of intervention. This is a different variation of what I showed you before. What I showed you before was the issue of if you hit how many of the 8 criminogenic needs that you hit, right, that you respond to. This talks about the impact of adhering to the R&R principles. Once again, if you ignore them, you pretty much make folks worse. If you adhere to just one of them, you're doing better than nothing. You're doing better than 0. If you hit 2 of them, you have a very nice increase. And if you adhere to all 3 of them, you have the best increase. But once again, you may not be able to adhere to all 3 at once or at the beginning. It doesn't mean that you don't start following the R&R model and that you don't pick at least one of the principles to utilize in the work that you do. Now, to be clear, when we talk about this issue of utilizing principles, it's not a willy-nilly choice. If you're going to utilize one principle, it's got to be the risk principle. If you're going to utilize 2, you've got to add the need principle. And then the third one is the responsivity. You can't choose to start with responsivity and ignore the risk principle or the need principle. So if you follow just risk, you'll have an impact. If you follow risk and need, you'll have a great impact. If you follow all 3, including responsivity, you will have the best impact. And then there's the issue of quality assurance, because in fact, it's not just knowing the principles, it's following them. And this is from a study that was done a few years ago in Ohio, looking at some of the halfway house outcomes and basically looking at it as a function of adherence to the principles. And basically what they used was a rating scale, a correctional program rating scale, and they basically looked at the alignment with risk, need, and responsivity between the staff skills, the leadership, the evaluations going on in the program, how the curricula were used, et cetera. And bottom line, no surprise to you, the greater adherence to the principles, the better outcomes they have, the worse adherence, the less. So when we talk about this issue of quality assurance and continuous improvement, this is a very nice model. It comes from NIC several years ago, from the National Institute of Corrections, and it is a very nice way to think about this whole concept of continuous quality improvement. And it really starts out at the bottom and builds up to the top. Starting out at the bottom, what you're looking at is that you need to start out with this concept of risk and need. Again, remember what I said earlier, that when we're talking about risk and need, when we're talking about the 3 principles, you start with risk, you move to need, and then responsivity is the third one. So the first issue is looking at risk and need, assessing for level of risk using actuarial or validated risk tools. The second piece is enhancing the intrinsic motivation. This is where we were talking earlier about the issue of motivational interviewing or other motivational enhancement responses. First issue, again, I need to know what I'm dealing with in terms of this individual's risk of recidivism. Second issue, I need to make sure this person has the appropriate degree of motivation to be able to work on change. Third issue, I now need to make sure the right intervention is being utilized, which means everybody doesn't get the same thing, and it means that the kind of intervention was developed to lower the risk of recidivism. The fourth issue, and I want to emphasize this, it's called skill training with directed practice. This is what it means. Some of you out there are no doubt saying we do cognitive behavioral interventions, and we use program A, B, C, or D. And you do. But here's my challenge to you. How do you do them? Do you basically sit down in a circle with folks and go through the exercises and the homework and talk about it? If that's what you do, what you're doing is an education group. You are not doing the cognitive behavioral change interventions necessary. Because remember, what we are doing is habilitating. We are creating change. What that means is people need to practice. If you have an hour and a half with folks and you're doing a cognitive behavioral intervention, 30 minutes of that should be spent with people actually practicing how to behave appropriately, how to do the different things that are in the lesson. That is skill training with directed practice. The fourth one is increasing positive reinforcement, and without going too in-depth around that, bottom line is that positive reinforcement is the most powerful form of reinforcement, and we don't do enough of it. We do a lot more negative reinforcement, and yet the research is pretty clear. If you want long-term change, you need to positively reinforce folks for change at about 4 times the rate that you negatively reinforce. And then there's the issue of engaging in ongoing supports once the person's in the community. So this is a very nice ribbon pyramid, if you will, of the things that we're talking about and how to effectively put R&R into practice. And then what you see circling it is the issue of quality assurance, right? The issue of measurement, which has to happen consistently throughout all of these processes. We'll now move to part 3, which is integrating treatment and services, behavioral health, and criminogenic risk. Bottom line is that, first of all, folks, this is true for all of you, but particularly JMHCP folks, I want you to listen to this fact. Incarceration is, in fact, not always a direct product of mental illness. In fact, recent studies suggest that it is the exception, not the rule, in terms of the reason for incarceration. And what you see here is that direct effect is about 19%, right, in terms of SMI, and then you'll see some numbers in terms of direct effect of substance abuse, and then you will see direct effect of other factors. And I apologize, let me state that better. Direct effect of SMI at 66%, indirect is, sorry, the colors on my screen are not matching up here, so I apologize. Direct effect of SMI is about 19%. Indirect effect is about 7%. Direct effect of substance abuse is about 4%. Indirect effect of substance abuse is about 4%. Other factors account for 66% of the total. Translation, it turns out that a good number of folks who have a mental illness who get into the criminal justice system also have some of the central 8 criminogenic factors. Again, remember what we're talking about: antisocial behaviors, antisocial personality patterns, antisocial cognitions, antisocial attitudes and peers, difficulties with employment or education, substance use disorder, and difficulties with family and intimate relationships. Now, the problem, unfortunately, for folks with behavioral health difficulties is that we arrest them more, we stress them while they're incarcerated, we keep them incarcerated longer, we don't give them access to adequate mental health care, and they're way more likely to fail on community supervision regardless of their level of risk. And so one of the things that we really need to think about is how folks here And when I say folks here, I don't mean just the JMHCP grantees. I also mean the SCA grantees, the reentry grantees. How, through the work that you're doing, can you improve the success rate of folks with behavioral health disorders? And what we think about here is how we, through our technical assistance, can help you do that. So whether you are a JMHCP grantee or an SCA grantee, you will hear from us during the course of our time with you about how to think about and why you need to think about folks who have behavioral health difficulties and how you can work with them. Traditionally, if somebody has a behavioral health problem, the typical reentry programs will say, they need to go to the community mental health center. Well, they may need to go to the community mental health center by all means. But if they are moderate or high criminogenic risk, they also need your programming. So they're going to need both. Behavioral health, if we just look at community mental health centers, have typically focused on the bottom 4 items here, and then to some degree with substance abuse. They haven't focused on the top 3 items that you see on the right-hand side here of dynamic risk factors. And for those of you that joined a little bit later, early on we were discussing this. These things on the right are what are called the central 8 criminogenic risk factors. And those are the things that I have been referring back to several times as I have been talking. Now, the good news is that good mental health services do focus on the bottom 4 items and to a degree on substance abuse. The bad news is for folks who have those problems and need mental health treatment, but who also have higher criminogenic risk, meaning have the top 3, doing those bottom ones will not solve the problem. You have to respond to both the bottom set of issues and the top. Reentry programs, this is why you need to be in the mix. This is why what you do in your cognitive interventions are also very important for this group. These folks need both of the types of interventions. So because of that, what we've done over the last few years is developed a framework to think about this. And we built upon folks that have done this work already. This was done several years, this framework that you see in front of you was done several years before we developed ours, and it really was it was developed with the folks from NASDAD, the National Association of Substance Abuse folks, and also the National Association of Mental Health Program Directors, and a number of other collaborators with them. And they were really looking at the intersection specifically between mental illness and substance use disorder, and they were trying to make a determination in terms of severity. If you had low mental illness and low substance abuse, well then what would you do, what would you need? And they were suggesting what you needed was sort of a primary health care response. But if you had really high levels of severity in terms of both mental illness and substance use, then you might be going to category 4 there, where you'd be in a state hospital, where this was at a time when there were far more state hospital beds. You might be in jail or prison for a variety of reasons, emergency rooms, et cetera. And if it was high substance abuse, low mental health, then you just need substance abuse treatment. High mental health and low substance abuse, you just need mental health treatment. So this was a very helpful cube, if you will, set of categories that was developed a number of years ago. But as you can see, it didn't actually get to the issue of dealing with folks in the criminal justice system. And so Dr. Fred Osher, myself, and a number of our colleagues in the last few years developed in association with a variety of other groups, including the same ones that I just mentioned, the National Association of Mental Health Program Directors, National Association of Substance Abuse folks, and ASCA, the Association of Correctional Administrators, developed this framework. And we're not going to go in depth to it. I will tell you that you can find the whole framework on our website, and you can find the whole publication, on our website. But this is why when I say to you reentry folks, you need to think about behavioral health. And this is why when I say to you behavioral health folks, JMHCP folks, you need to think about the issues of crim risk and behavioral health need, because these things are very closely related. And what you see here is really thinking about these folks in a very holistic way, starting out at looking at the issue of what their criminogenic risk is. Because remember, even if we have a mental illness problem, that a significant number of those folks have significant criminogenic factors. Next issue is looking at the substance abuse need, and then looking at the mental illness need in terms of severity. So we're looking at severity of crim risk, severity of substance use issues, severity of mental health issues. And we are then breaking them down into discrete categories, looking at where they might fit, and then suggesting, not for the purposes of this conversation, but in the document that you can get on our website, suggesting different sets of responses for those different folks. And what I can tell you, to be grossly simplistic about it in a quick way, is that folks toward the left side of this scale, you're looking at community and fairly low level of correctional intervention. We don't need to waste correctional resources. Folks in the middle, you're looking at a bit more correctional resources. Folks toward the end, you're looking at a lot of correctional resources and a lot of behavioral health resources. Again, way too complicated to go in depth in this particular overview, but I do want to alert you to it. I do want to point you to the fact that you can go to our website and take a look at the document. Now, the best model when we're talking about folks who are in the criminal justice system who have co-occurring disorders is really an integrated treatment model. Rather than have folks get individualized treatment, rather than have folks go over here for one kind of thing and over there for another kind of thing, that actually doesn't work very well, not surprisingly. And if you think about it, it makes a lot of sense, right? Somebody has a lot of difficulties, a lot of challenges, and we suggest that the way that they can improve that is to go to 7 different places on 6 different days to meet 5 different people in order to solve their problem. And then we get confused when they don't show up. Well, that's because that model tends to not work. The traditional models of treatment for folks with dual disorders or co-occurring disorders really have resulted in poorer outcomes. No treatment obviously gets them into the ER, gets them arrested in many cases or into hospitals. Sequential treatment, meaning you do one thing then another, has not worked very well either because, among other things, the sequencing got chosen based on what was available, not based on what was needed. And then secondly, it ignored the fact that the different problems actually feed one another. And so while doing a great job on one of the problems, the failure on the other type of problem or set of problems actually ends up increasing the failure even if they got good intervention on the first problem. So the idea of first we'll do this, then we'll do that. Substance use treatment is a great example of that for those of you that have been around for a while. We used to say that you do that first for a year and then you do everything else. The problem is, of course, while you were doing that first for a year, at least if you were in the criminal justice system, you then failed because of the everything else that you weren't resolving. And so what we're really looking at is talking about doing these things together. Parallel treatment is what I was just mentioning, right? Yes, you're giving them the 5 things, but it's all over the place. The burden is on them. It tends to not work very well. Folks don't communicate very well with one another, and you end up with fairly significant fragmentation. So integrated treatment is really the most effective. Regrettably, it is also the least done currently in the United States. So when we're talking about integration, we're talking about 3 levels of integration. We're talking about system integration, which is how the systems collaborate in a better way. For example, mental health, community justice, and substance abuse systems. We're talking about service integration, how we don't have to send people to 7 different places to get what they need. And we're talking about interventions that are integrated because there are ways or strategies and techniques, if you will, in which you can combine all of the interventions into a single either contact or a series of contacts rather than having them be in multiple settings. And again, this is what I was just mentioning, which is that unfortunately, while there's good news in that we now have more people getting some treatment than not, what we still see is that only about 11% of folks get the necessary integrated treatment. There's far more mental health care available than there is substance abuse treatment, or I should say far more folks get that treatment. But the bottom line is that when we're talking about the folks that we work with in the criminal justice system, that 11% should really probably be something like 50% as opposed to 11%. Now, treatment does work, and that's important. Medications, therapies, and supports really help people manage the psychiatric symptoms, really allows folks to lead very successful and productive lives. And I know that right now we have the headlines of the German pilot, and we've had a number of different things that have occurred historically with mass shootings and mass violence, and those are very serious issues that, again, would require could take a whole nother webinar to talk about. The bottom line is that as horrific as those things are, they truly are the exception and not the rule, and the vast majority of people who have a significant mental health difficulty can indeed lead successful and productive lives. And in fact, we can manage mental illness disorders or mental disorders easily as effective as we can manage, and in some cases better than we can frankly manage some physical illnesses. But even in the best case scenario, it is possible that somebody can relapse. Recovery can be slow. That's just the way that it is. Cure is really possible. It's a word that we probably shouldn't use the way that we do. And frankly, it's really not necessarily the objective. Even in the best cases, recovery can be slow, and what you see here is just an example of this, looking at folks who were folks in remission, and these are folks that were in high-fidelity ACT programs. So they were people with both had very high mental health needs, and two were in very high fidelity programs compared to folks that were in low-fidelity programs. And basically what it shows you is that even in the best programs, it takes time. It doesn't just happen. And it's also important to understand that relapse does not mean treatment failure. The bottom line is that there will be relapse. And this is, in the correctional world, we get uncomfortable with this, right? We talk about relapse prevention a lot, and we talk about it as if relapse prevention means that people won't ever fail. But in fact, that was never the original construct of relapse prevention. And it is true that people will take 2 steps forward and sometimes 1 step back, and occasionally 2 steps forward and 3 steps back. And we need to understand that. Now, obviously, there are certain dangerous behaviors that cannot be tolerated. But very often, we will remove the opportunity for success from people because they have relapsed with something that is not dangerous to the community. And we take away the potential, rather than use the relapse as a learning opportunity and to improve further. Again, community safety always has to win, but so many of the things that we see when people are, for example, violated or terminated from programs are not because they've done something that's dangerous, but because they broke a rule, which arguably is exactly why they're in trouble, because of rule-breaking behavior. And perhaps what we need to be doing is helping them learn when they break a rule how to change that behavior, rather than give a response that actually will not teach them how to change the behavior, but is simply another punishment, again, assuming that the behavior is not a danger to anybody. So there are a number of challenges when we talk about the issue of staff development, and I've touched on some of them already, so I will not go through these in any in-depth way, but the one that I really want to mention is the issue of making sure that you develop resources for continued monitoring and coaching. That is just so important. If your staff feel left out and alone and don't feel that they have the supervisory supports to make the changes they need, then that will not happen. So when we're talking about quality assurance, there's a number of things that need to be looked at, and excuse me, a number of things that need to be looked at, which include being able to track the recidivism rates of the individuals that you're working with. Might be looking at pre and post testing, might be looking at client file reviews, et cetera. There are a number of ways that you can assess what's going on, including utilizing the Correctional Program Assessment Inventory or the Evidence-Based Correctional Program Checklist, both of which are freely available from the web. There's also being piloted now in several jurisdictions, in conjunction with Faye Taxman and George Mason University. We're working in several jurisdictions piloting what is called an R&R simulation tool, which allows jurisdictions to look at how well they are actually implementing the principles. And again, there are, as always, challenges looking at the issue of staff capacity, the necessary resources, and how it is that you reinforce appropriate performance. I would argue from a resource perspective, if in fact you are doing none of the things that we've talked about today, then you will not make it worse by having one or two less people doing that. And you might as well move them over to what we're talking about to make the changes and to do the training. Because while you may be very busy now, the impact that you're having is likely very poor if you are not following these principles. In fact, I'll make it a stronger statement than that. If you're not following these principles, there is no known way that your impact can be statistically significant. And last but not least, there's the issue of the evaluation system. For those administrators in the audience or those supervisors in the audience, please, please, please make sure that your personnel evaluation system is in line with what you want to do in terms of integrating the risk-need-responsivity model and all of the principles into the work that are done. We naturally, as employees, do what we are rewarded for, and we naturally follow what we are evaluated on. If what we are evaluated on is different than what we are being told to do, you will see the disconnect and you will not see the change. It is also a very helpful way for people to be able to understand in an ongoing way what it is that they need to be doing. That happens because of the continued discussions between the supervisor and the employer, and the employee. And it happens because in order to do these evaluations, you have to talk about the concepts that are being utilized, which is actually in and of itself a new learning experience. So I'm going to end with this issue of the evaluation system. You have to evaluate not just the programs, not just the system itself, but you must evaluate according to the principles we're discussing, the people that you wish to carry them through. And with that, I'm going to stop, and that leaves about 10 minutes or so for questions.
Great, thank you, David. We have some great questions from our audience. One of the first questions we received is regarding risk needs assessments. What part of the criminal justice population do you suggest that the system should target? In Angie Wood's situation, she said that her jurisdiction implemented a risk needs assessment for all felony cases after pleas entered prior to sentencing. What's your take on what's the right timing to be using risk needs assessments and who should be getting it?
Sure. So there are different forms of risk need assessment. There's pretrial risk assessment. There's pre-sentence. There's risk assessments that are done at a pre-sentence level. There's post-conviction. There is a classification that is done at entry into a facility, and of course there's risk assessment done upon release and upon community supervision. Those are in fact all valid places to do risk assessment. They are not all exactly the same types of assessment, and what you can do are different. So, for example, what you can do at a pretrial risk is different than what you can do at a post-plea pre-sentence. A post-plea pre-sentence is something that many jurisdictions are doing now. I certainly think that when I say I certainly, it would be generally seen that that is an appropriate thing to do. The part of what the court should have available to it in its decision-making is some understanding of what the risk and needs are. Now, having said that, there are, as always, a number of things that have to be considered. The first one is some folks just give a score, and that's not helpful. Other folks lay out all the items. That isn't necessarily helpful. Some of the best things that I've seen in pre-sentence investigations involve the officer has done whatever their risk assessment is that they're utilizing. And let's say it's an LSIR, for example, level of service inventory, or a level of case management, LSCMI, level of service case management inventory. They do that. They take from that what the particular items are. In their pre-sentence report, they say, based on the risk assessment, these are the key items that we have seen, these are the key criminogenic risk factors that we have seen, and this is what we recommend for the appropriate programming. What they do not say, and this is a different issue, what they do not say is, therefore, your sentence should be based on this. It is one piece of information that a judge should have available to him or her making decisions. So, two things. When in the system, the answer would be from the very beginning all the way through the very end, although there are different types of assessments one might utilize. And a nice example of that would be the Ohio Risk Assessment System, which has built into its system several different risk assessment tools that are utilized. There's the PAT, which is the pretrial assessment tool, all the way through to the post-release assessment tool. And again, you can access that on the web at no cost. Whether you use it or not, it's a nice way to conceptually understand this idea of, this is what I can assess early on, this is what I assess in the middle, this is what I assess later for different supervision planning and thinking.
Great. We have lots of questions about tools, the risk assessment tools, and the collaboration happens between the different entities that work together. So one question has been, if correctional-based programs use one tool and community-based programs use another tool, how can these tools, the results from the tools be compared, utilized, since the tools are different? What can we do to make sure the results are right when different agencies are using different tools?
Yeah, that's a complicated factor, by all means. The first thing is that you shouldn't, if it's at all possible, you shouldn't be using multiple tools in a jurisdiction. That does create an unnecessary degree of confusion. Having said that, assuming both the tools you're using are validated, and they are both validated on your population, you should not be getting a massively different result. Where the problem comes in is that the language is different. Tool A uses the word uses the words mild, moderate, and severe. Tool B uses low, medium, and high. And so you get this sort of language disconnect. But if, in fact, both tools have been validated on your local population, you shouldn't see a substantively different outcome. In other words, you shouldn't see tool 1 giving you a low and tool 2 giving you a high. If you are, it would suggest one of several problems, that being that one of the tools wasn't validated, 2, that they weren't validated correctly, 3, that the people doing them weren't trained correctly, or at least one of the people doing them weren't trained correctly. So there's a number of ways you can see that. But let's say it's all done perfectly. You do still have that issue of language. And that is an ongoing problem. I will tell you that we are working with a number of testing experts and researchers and Corrections Canada to, in fact, develop a common language model so that regardless of what tool is being used, moderate in tool A will match moderate in tool B, and you won't be talking moderate versus medium or moderate versus kind of low, those sorts of things. Again, we're probably 18 months from there, but that is a very real problem. Ideally, for a number of reasons, using different places using different tools isn't the best plan. And one of the reasons is that you should have a case plan that starts at the beginning and follows you all the way through. And so if you constantly have all of these sort of fragmented things happening, which honestly is currently the norm, then it just makes it much more difficult. So to the degree that in any jurisdiction you can sit down and say, hey, how can we do this? How can we even share the necessary information? Because do you always have to redo it if it was just done? How do we share that information?
Okay, thank you. Related to that, some folks have asked Is it essential to use risk assessment tools that are validated? What if we aren't? What are things to keep in mind when trying to validate your risk assessment tool?
Okay, yes, you must use a tool that is validated. There is no question about it. Otherwise, you don't have a risk assessment tool. What you have is a bunch of questions. They may be good questions, but you cannot draw any significant conclusions from them if they have not been validated, meaning they have not been shown to have some predictive ability. There's actually two issues. One, have they been shown to have some predictive ability? The other issue is, are they really measuring what it is that you expect to be measuring? And you know, if you don't validate a tool, then you can't know that. Do you have to take an off-the-shelf tool? Can you create your own? Yes, you can, and then you have to have the appropriate research folks validate that tool by going through the necessary steps with your population, looking at the individual items first, and then applying it to the population and looking at the results. To be honest, despite the fact that many jurisdictions like to create their own tool and even validate their own tool, it's probably not particularly necessary. It's probably just as easy to take and definitely as valid to take a tool that's been developed, such as the Ohio Risk Assessment Tool, and validate that for your jurisdiction. There's a lot of recreating the wheel that goes on, and often what happens is people put in something that is a pet issue for them, but in fact doesn't have a predictive component to it. And so whether it's taking some of the off-the-shelf ones that are sold, or it's taking some of the open source ones like the ORAS, you can take those, validate them in your jurisdiction. You don't have to start from scratch, and you will have very good outcomes in terms of what it is that you're doing.
Another question related to understanding criminogenic needs. Can you explain why or how does substance abuse, what's its relation to causing the big four criminogenic needs?
Sure. Substance abuse doesn't cause the big four criminogenic needs. Substance abuse is a factor. It is a criminogenic need in and of itself, and it is a responsivity factor, meaning it can get in the way of treating or effectively responding to the big four. But substance abuse doesn't create, for example, antisocial behavior. Let me restate that. Of course, it can create bad behavior, but to have bad behavior, you have to have antisocial thinking. And so, if you'll forgive the expression, you have folks that are mean drunks, right, versus folks who are not. It's not the alcohol that made them that way. The alcohol essentially was the trigger for something that was there, for lack of a better way of putting it, the meanness that was there, or the other issue that was there. And so it's a disinhibitor, it's a triggering mechanism, but it does not cause one to have an antisocial personality or to have criminogenic thinking. What has been true historically is that initial research indicated that it was a weak driver. Recent research by Faye Taxman and others is suggesting that it's possible to not have the big four and still have a higher failure rate if you are substance dependent, not necessarily just use substances or even some abuse, but are substance dependent. So there's some new research that's suggesting that we may need to target substance abuse in a more powerful way through the criminal justice system response, meaning assure that they get that treatment rather than just referring them to a community provider, even if they don't have the big four. That research is young. It has not been replicated tremendously at this point, so we're still, a few years from that. I suspect, though, based on the initial information that we've seen, that there will be a much greater focus on responding to substance use, substance dependence specifically, regardless of the issue of the big four.
Thank you. And last question, but we have a ton rolling in, and I'd like to thank everyone in the audience for submitting their questions. You should definitely be following up and reaching out to your technical assistance provider with follow-up questions. You'll be getting a webinar archive as well that you can share with your staff. But last question for now, and then we'll have to conclude, is how do these R&R principles apply to juvenile programs?
Great question. Completely. The principles apply. How you put them into play change a little bit. But it's interesting in that most people don't realize that the original R&R studies done back in the 70s and 80s, late 70s, early 80s, actually were looking at the adolescent histories of the men that they were dealing with in prison. So the principles are very valid for juveniles. And so now I need to point folks to another one of our publications that was recently put out looking at the issue of appropriate responses to juveniles. And of course, I'm blanking on the title. Cynthia, can you remember the exact title of that publication? If you'll look that up while I'm talking about it. But the publication focuses on the issue of risk, need, and responsivity in working with juveniles, as well as looking at the issues of positive youth development, which is obviously a very key issue. But it's very similar in the sense that if you, from our perspective, based on the data that we have seen, and at this point we've seen a fair amount of it, if you work on the positive youth development for youth that have the criminogenic risk factors, you won't get the outcomes you want, and you will see them ending up in the adult criminal justice system. So that what we're saying is you need to do something very similar to what we're saying around the behavioral health framework, which is that, of course, you need to work on all of the positive youth development components, but at the same time, you need to be looking at how to reduce recidivism following the R&R principles. The title of the document, folks, is Reducing Recidivism and Improving Outcomes for Youth in the Juvenile Justice System. So that's Reducing Recidivism and Improving Outcomes for Youth in the Juvenile Justice System. And if you Google that, it will bring you right to the website, and you can download the PDF of that.
Excellent. Thank you so much, David, and thank you again to everyone who participated today. We will be following up with an archive of this webinar, and do please subscribe to our newsletter if you haven't already, and reach out to your technical assistance providers with any follow-up questions, and we'll be making sure to circle them back to David.
And one thing that we will do is that if we seem to have enough questions, we will do another webinar sometime in the next month or two that basically will be designed to answer the questions, to respond to the questions.
Thank you.
Thank